Good morning, folks. I'm going to go ahead and take attendance, and then we can go ahead and get started. Okie dokie. So exam 2 is on Thursday. This will be the same format as last time, where you will end up doing multiple choice, matching, short answer, and then short essay. My biggest tip is, as you're writing the short essay, there's a rubric associated with it. You should be able to see it's also embedded in the question itself, and just make sure you're hitting every point, and think about the fact that each point is worth 5 points, right? So kind of write enough to be a 5-point answer for each. This is just going to happen today. We're just going to have to roll with it. There were review sheets. Hello, Simba. Thanks for knocking that over. There's a review sheet posted on Blackboard, and make sure that you do the clinical choices activities beforehand, because you will be asked to write about one of those on the short answer portion. Sign on like you did last time, and then we will spend the time on Zoom in case you need to ask questions. So as per usual, we will have that option. Alrighty, I'm going to go ahead and get started, just because this is a lot of slides to cover in a day. There's some things I'm going to skim over that I probably spend too much detail on this PowerPoint, but I want to make sure I go slow enough that y'all can actually understand me. This is so helpful to have you right in front of my screen where I can't see. Yeah. Okay, you guys can't even see him, but he's literally right here. So let me go ahead and get our PowerPoint set up here. Yes, hi, go boy. Yeah, but I need to be able to use my mouse. Thank you. Okay. And then, sorry, he's literally got his butt right in front of the share screen button. There we go. Okay, yes, I know you want all the attention. I'm going to go ahead and open the chat. Feel free to ask questions or make comments there as usual. And I have my Pro Science, Pro Vaccine, Pro Dolly shirt on, because today I get my second Moderna vaccine, which Dolly Parton helped fund with her foundation, if you didn't know that. Dolly Parton's even more of a badass than you thought. So today we're going to talk about trauma and stress-related disorders. And in particular, we'll focus a lot of time on PTSD and acute stress disorder, but we'll talk about stress in general as well. And obviously, this is something we're all very familiar with, particularly on sort of the 1-year anniversary of us going into quarantine or stay at home or whatever you want to call it, right? I haven't been in a grocery store in literally a year now. So I cannot wait for the 2 weeks after today when I can just like go in a place double masked, right? And that creates a lot of stress for folks. So what is a stressor? That's an event creating demands, an event creating demands. And then a stress response, yeah, okay. Off the keyboard, thank you. Thank you. A stress response is a reaction to those demands. So your reaction to the demands is your stress response to the stressor. And this is influenced by how we appraise both the event, the stressor, and our capacity to react to the event effectively. So if it's something where it's just overwhelming, right, our stress response is probably going to be less adaptive. And people who sense that they have the ability and resources to cope are more likely to take stressors in stride. Eustress is a term that often surprises people. Eustress is positive stress. And you might think, like, what the heck's positive stress? Why does that exist as a thing? Well, positive stress can be when there's an awesome thing coming up, but it's a lot of stress preparing for it. My example that I always use is planning my wedding. It was really fun to plan my wedding. We got to like taste a whole bunch of cakes and things like that, but it was still pretty stressful, right, to have to check off all those boxes. Distress is more of what we think of when we think of stress. It's negative stress. And we use the term distress colloquially in this way. Fear can be a part of stress as well, which is why these disorders used to be categorized with the anxiety disorders, but in the DSM-5, they decided they're distinct enough to warrant their own category. And in fact, your textbook predates that decision. They've had a separate chapter for stress ever since I first started using this book, I believe in 2006. So go Comer for kind of being ahead of the curve. But fear is a package of physical, emotional, and cognitive responses. So physical, emotional, and cognitive responses. How you feel physically, the emotions you're experiencing, and what you're thinking about, those cognitive responses. So we've talked about the fight or flight response in the context of anxiety disorders. It's also involved here. And this is an inherited tendency to defend yourself or protect yourself in the face of danger. So it's an inherited tendency to protect yourself or defend yourself in the face of danger. And it's overactive in folks with these stress disorders. So the book goes into way too much detail about the biology of the fight or flight response. Don't worry about that. That's not going to be on the test. So after trauma, many people will become highly anxious and depressed. And for some people, this will pass, but for others, these feelings will persist well after the trauma. And typically what we look for when we're thinking about what is a traumatic event, what is trauma, it's actual or threatened serious injury to self or others. If it's to others, you have to witness it or sort of hear about it in graphic detail. One of the things I liked that they did in the DSM-5 is included seeing something virtually or digitally if it's part of your job. So when I was treating vets at the VA, I had a guy who had PTSD because his job in Iraq was to just watch CCTV footage all day and helmet cam footage of things like marketplace bombings and things along those lines. And he obviously developed PTSD symptoms from this, but at the time it was unclear whether I could actually diagnose him. I did, but the DSM-5 makes that much more clear. So there are two main psychological stress disorders. The first is acute stress disorder. And so this is where symptoms begin within 4 weeks of that traumatic event, and then they last for less than a month. The symptoms are still overwhelming, they still get in the way, but they pass. PTSD, the symptoms can begin at any time following the event. It could be a month later, it could be 6 months later, it could be 6 years later, it could be 30 years later. When I was at the VA, we had Vietnam vets, so from the 60s and 70s, who were coming in 2009, 2010 to be diagnosed with PTSD for the first time. And so they can come out of, PTSD can come out of acute stress disorder. So you can be diagnosed with acute stress disorder essentially right after the trauma. And then if those symptoms persist more than a month, you can be diagnosed with PTSD. But I would say probably the vast majority of people diagnosed with PTSD are never diagnosed with acute stress disorder first, not because they necessarily didn't have it, but typically folks don't seek help until quite a bit of time afterwards. And about 80% of people who do develop acute stress disorder go on to also develop PTSD. All right, so this is the list of symptoms for PTSD, and this is one of the more complicated diagnoses in the DSM. So I'm going to take probably longer than I usually would on the symptoms, but I think it's really important to do so to understand. So acute stress disorder basically has all the same symptoms, just for shorter periods of time. And essentially, this is, you have to have an exposure to what we call a criterion A event, because in the DSM, instead of being labeled 1, this is A. And this is exposure to actual or threatened death, serious injury, or sexual violation in one or more of the following ways. So directly experiencing it yourself, witnessing it in person, learning that the traumatic events occurred to a close family member or a close friend, and that must have been violent or accidental, and experiencing repeated or extreme exposures to adverse details of traumatic events. Again, this includes it through electronic media, TV, movies, or pictures if it's part of your job. If you just play a lot of Call of Duty, that wouldn't qualify for a criterion A event. Then you need to have a presence of one or more of the following symptoms. And these are called the intrusion symptoms or intrusive symptoms. And these begin after the trauma occurred. So recurrent, involuntary, and intrusive distressing memories. So these will just like come out of the blue, or something will be tangentially related and all of a sudden you're remembering the event. Just recurrent distressing dreams, nightmares related to the trauma. Dissociative reactions, these are flashbacks, in which the individual feels or acts as if the trauma is reoccurring. So if you've ever known someone who's like a Vietnam era vet who has PTSD, if a car backfires, they'll hit the deck, because to them that sounds like a gunshot. For some of my OIF vets, Iraq and Afghanistan, it was all of a sudden they'd find themselves driving down the middle of the road because the IED that caused the explosion they were part of was on the side of the road. For individuals who survive sexual violence, it can be in the middle of consensual sex. So that obviously is very disruptive. Intense or prolonged psychological distress at exposure to any type of cue, internal or external, that reminds you of the trauma. And marked physiological reactions to reminders of the trauma. So this can include things that are like a panic attack, shallow breathing, heart racing, those type of things, sweating. And then you need to have the presence of an avoidance symptom. So persistent avoidance of stimuli associated with the trauma. Again, that began after the trauma, like if your trauma was tangentially related to a spider and you were always afraid of spiders, right, that wouldn't count. But, if it took place in a creepy basement and now you can't go in basements anymore and you never had that problem before, that would count. So it's got to be one or both of the following, either avoidance of distressing memories, thoughts, or feelings about the trauma, and or avoidance of external reminders. So this could be people who were present at the time of the trauma, places where the trauma took place, activities, situations, conversations that are going to bring around distressing memories, thoughts, or feelings about the trauma. So this can make people's worlds really small. It can isolate them from friends and family if they were present. Let's say you were in a car accident and your family was all in the car with you, right? If they remind you of it, you might start avoiding contact with them. This can also get in the way of work. I had, I believe, Iraq vet who had gotten out of the service but worked for the Army, civil service now, and he left the room whenever anyone talked about Iraq. When you're working for the Army, that happens a lot, right? So it was getting in the way of him being able to be productive at work. And then you have negative alterations in cognitions, thoughts. and moods, emotions associated with the trauma. And this begins with the trauma, or if you already struggled with this, it worsens after the trauma. And you've got to have 2 or more of these. So inability to remember important aspects of the trauma. Sometimes this is just a blank for the entire traumatic event. Persistent negative beliefs or expectations about yourself, the others, in the world. That negative cognitive triad for depression shows up here as well. Persistent distorted cognitions, thoughts about the cause or consequences of the trauma that lead to self-blame or blaming others. So this is actually a lot of what one of the types of therapy for PTSD focus on is the self-blame aspect. Persistent negative emotional states, so just always feeling fear, horror, anger, guilt, or shame. Anhedonia, that not wanting to engage in activities you usually enjoy. Feelings of detachment or estrangement from others. And the persistent inability to experience positive emotions. That same low positive emotionality that we talked about when we talked about depression. And then you have to have 2 or more marked changes or alterations in arousal and reactivity associated with the trauma. Again, beginning or worsening after the trauma happens. So irritable behavior and angry outbursts. Reckless self-destructive behavior. Hypervigilance is always being on your guard, always scanning your environment. If any of you know veterans, law officers, law enforcement officers, oftentimes when they go to a restaurant, for example, they sit in a corner so that no one can sneak up on them. They can kind of see the whole thing. I had a client who had knee injuries as part of his, experience from Iraq and Afghanistan, and he would still patrol his entire 2-acre property every night. That was part of his hypervigilance. An exaggerated startle response. So if you do manage to sneak up on these people, they're going to jump a mile. And then problems with concentration and or sleep disturbance. So again, it's got to last at least a month. Typically, the person will have been experiencing symptoms much, much longer. And it's got to cause clinically significant distress or impairment, which it does for these folks. So some stats here, the lifetime prevalence of experiencing at least one traumatic event is about 50% for women, 60% for men. This is an older stat. I would be interested to see if that's sort of equaling out as more women join the military. Approximately 7 and 9% of the general population meets criteria for PTSD at some point during their lifetime. Women develop it more often than men. So after experiencing a trauma, more women than men do develop PTSD. And there's a bunch of reasons for that. One is that we know that women are more prone to anxiety and depression. Another is that, kind of like we talked about with depression, it's more normalized for women to seek help. So it's possible we're missing diagnoses in men. And then some events like combat, disasters, abuse, and victimization are more likely to cause disorders than others. We know that women are much more likely to be the victims of sex crimes, of domestic violence, of crimes like happened in England, right? Where there was a young woman just on her way home and a police officer actually assaulted and killed her, right? So we know that those things occur more often to women. So how about, well, what types of trauma are more likely to bring out PTSD? So in general, again, 7 to 9, 8 to 10%, somewhere in that order. If you're wounded in combat, that jumps to 20% of those folks. If you've been raped or sexually assaulted, 50%, which I always think is really interesting because it's the same percentage as people who've been prisoners of war, right? So it represents a very life-changing event that I think is often sort of dismissed in our society, and that's really problematic. And if you've had repeated high levels of combat exposure, it's about 60% of those folks develop PTSD. So here's some of the common traumatic stressors. I've mentioned some of these in passing already. So disasters is one I haven't mentioned yet, but tornadoes, hurricanes, floods, earthquakes, fires, things along those lines. Other things that would go here would also be terrorist attacks, right? I'd be very surprised if there weren't some senators and representatives who developed PTSD after the events on the Capitol in January. So abuse, if you're physically, emotionally, or sexually abused. Combat and war-related traumas is where we typically think of these things. This is actually where this diagnosis first sort of developed. So they talked about it as combat fatigue syndrome or shell shock. And then eventually that diagnosis became PTSD. And eventually we recognize that if you experience a different kind of trauma, you have the same symptoms. Other common traumatic events, car accidents, sudden deaths of loved ones. So disasters, we see acute or post-traumatic stress disorders following natural and accidental disasters. And civilian traumas have been implicated in stress disorders at least 10 times as often as combat trauma. And that's simply because more civilians experience these things than there are people in our military, right? And often people in the military have some sort of prep. So I remember when I was working at the VA, we did a workshop where they shared some of that prep material they share with folks before they're deployed. And it's like Steel Your Battle Mind, and it shows them some of the images of what they might run into, and it discusses smells and sounds and sights and things like that. The average person doesn't have anything like that. 1/3 of car accidents may develop PTSD within a year after the accident. And something like Hurricane Katrina causes more people to develop PTSD due to the fright of experiencing the hurricane itself, as well as seeing the aftermath. The city flooded, people dying, people being displaced. All right, so here is where I have a lot, because when I was doing clinical work, I worked quite a bit with survivors of sexual assault. Unfortunately, this is more common than you think, and a decent percentage of these folks develop unhealthy relationships with their bodies as a result that can lead to disordered eating as well. And also a big part of what I did at the VA the year I was there was to work with survivors of military sexual trauma, which are folks who have been sexually assaulted by a fellow service member. So not someone on the other side, someone who should be a supporter, right? So people who have been abused, victimized, or terrorized often experience lingering stress symptoms in general, even if they don't end up meeting criteria. So about 1 in 7 women is raped at some point during her life. For college women, it's somewhere between 1 in 3 and 1 in 4. For college men, it's about 1 in 7. It's, you know, a bigger disparity for men outside of the college setting. Although it is also a problem when men are sexually assaulted in the military by 4 other men, typically. And one study found that 94% of rape survivors developed at least symptoms of acute stress disorder. So again, this is a very traumatic event. This is also really common among those who are sexually abused as a child, and many don't receive the care they should for a whole host of reasons. It's not available. There's too many barriers to seeking it, or there's a lot of guilt and shame or denial associated with it. So again, here are some stats. I'm going to just skim over these. Here you go. About 1 in 33 men in the general population. Again, college, it's hard for us to know these statistics because we think, again, it's hard to tell, but about 95% of college sexual assaults go unreported. But somewhere between 20 and 25% of women are sexually assaulted during their college career. And again, about 1 in 7 men. 90% of women know their assailant, so it's not some guy in the bushes. 42% tell no one about the assault. Again, there's a lot of shame associated with it. People can't necessarily name it as such. And there are 10 times more rapes reported to crisis lines. So hotlines like the YWCA in Norfolk has than are actually reported to the police. So that's one of the ways we start to get at, you know, how many are out there that we're not actually seeing going to the police. And there's a lot of reasons why people won't go to the police. Often they're not believed, often they're blamed, often it can be just as traumatic, if not more so, to report. You know, if you undergo a rape kit, it's very invasive, right? And some women just don't know how to or who to go to get help. So sexual assault is linked to both mental and physical health problems. So about 40% of people who are assaulted end up with an STI, STD. 80% end up with physical or psychological problems that are chronic. They're more likely to attempt suicide. And only a quarter to maybe half actually seek out mental health treatment. So that means there's a lot of people out there. Good question, Romina. How do we estimate the percentage of people who tell no one? Anonymous surveys. So if it's actually even easier to do it online now, right? So if you tell people like there's no way your information can be associated with your name, they're more likely to report it. But then we would also ask questions like, have you ever told anybody? It's still not perfect, right? It's still not precise. But yeah, there are people who don't tell folks for years. I had a client while I was on residency who came to me to work on PTSD related to a sexual assault when she was 17 that resulted in her getting pregnant and giving the baby up for adoption. And part of what you do in therapy for sexual assault is have the person write out their story, what happened to them. And when she came in the next session and she started reading her story, it was of a gang rape that happened to her when she was 13. And I stopped her and I said, wow, you didn't mention this. And she was in her 40s and said, I've literally never mentioned this to anybody. So yeah, you know, sometimes it's things like that, but often it's anonymous surveys. And then we hope that people are more honest because they know their information can't be associated. For example, there were a lot of surveys done in like the 80s and 90s where they talked to, you know, certain groups of college men that may be more likely to commit assaults. They're often men in very privileged positions. And I forget what the percentage was. I think it's about half of them, it might have been more, said that they would rape someone if they knew they could get away with it. So again, because it's totally anonymous, we get people who admit to stuff like that. It's really frustrating, right? So again, much more likely to suffer from mental health issues, including substance use issues. And different studies find different things. The chances of developing PTSD after being sexually assaulted are 50 to 95%, right? Again, big range depending on the sample. As I mentioned, these folks often develop eating disorders, about 18% binge and purge, whereas non-abused adolescent girls, only 6% of them do. So it triples your likelihood of developing symptoms of bulimia nervosa. 30% of those who have been abused use illegal drugs compared to only 13% who have never been abused. So they develop psychiatric disorders, they develop drug and alcohol abuse problems. And again, you're going to see different percentages, different numbers in terms of suicidal ideation or attempts, depending on the study you look at. Now, what happens if you're sexually assaulted while you're in college to your college life? Well, in nearly every case, victims cannot perform at the same academic levels that they did prior to the attack. They're often unable to carry a normal caseload. They'll miss classes more frequently. This will often be a result of social withdrawal or a way to avoid seeing the perpetrator on campus. We do have procedures in place at Virginia Wesleyan that if you're assaulted by someone and they're in one of your classes, you can get your schedule switched, no questions asked. And they'll like put no contact orders in place and things like that. But you have to report, right, for that to happen. And if you're not in a position to report, then, you know, you may just end up doing avoidance. Some will just withdraw from courses, drop courses altogether. They'll leave the school until they recover. Sometimes they'll transfer to another college. All right, so now we're going to talk about combat trauma. And again, it's been recognized in the psychology field that since World War II, we've recognized that soldiers experience distress during combat. But as early as the American Civil War, there was some acknowledgement that something was going on with the veterans. So this is called shell shock or combat fatigue. And post-Vietnam War clinicians discovered that soldiers also experienced this after combat. I mean, we kind of already knew, but they were the first ones to really write about this, that this lingers. So about 30% of Vietnam veterans suffered from a stress disorder. 22% had some stress symptoms. And at least 10% are still experiencing problems, you know, again, especially if they haven't sought help. So terrorism, I mentioned in passing. You are susceptible to PTSD if you are a victim of terrorist attack or if you live under the threat of terrorism. So the touchstone for me is September 11th. I know many of you may have been very, very young or not even born yet, but I was in college when September 11th happened. And there were really high rates of stress reactions to this. About 44% of the US population as a whole had some sort of stress reaction, maybe not a diagnosis level, but certainly problematic. And then the closer you got to the World Trade Center, the more likely you were to get it. And you see this with this second set of statistics, right, where you saw it more often in folks in New York. Although college students in general tended to have comparable levels across the country. And I think a big piece of this is that, you know, this was the first one of these disasters that had really happened in the time that internet access was fairly common, right? So we all saw the footage. We all heard about it, right? We all saw these stories about it. So it was quite overwhelming. And then Pentagon staff members, because people often forget, but the Pentagon was also attacked. Almost a quarter of them developed PTSD. So what causes these stress disorders? Well, lots of different things, right? So again, as we've mentioned, trauma is necessary. You need a criterion A event, but that's not enough. Not everybody who experiences a trauma also develops a stress disorder. So there are other factors that come into play, and all these different categories, and each of these will have its own slide as we go through. So biological factors. Traumatic events trigger physical changes in the brain and body. Even in the moment, it actually changes your ability to remember things in a linear order, for example. Most people can't after a trauma because the brain literally cannot do it. So that can lead to severe stress reactions or disorders. And some research suggests that there's norepinephrine and cortisol imbalances that are linked here. So that would make you more susceptible to develop a PTSD after a traumatic event. In terms of genetics, they actually did a twin study where both twins had been in Vietnam. And if one twin developed it, the identical twin was much more likely than if they were fraternal twins to also develop it. But we always have to keep in mind with twin studies that it's possible this is due to shared environmental factors, especially if the twins were in the same unit, for example, right? They may have experienced the exact same trauma. So it seems like there are some risk factors in your personality. So if you are someone who was already very, very anxious or has an anxiety disorder like panic disorder, GAD, what have you, then you're more susceptible to developing PTSD after a trauma. Just a past history of psychological issues in general can be implicated. And also just having that negative worldview, that negative cognitive triad, or just sort of being really pessimistic. So what's protective? Resiliency or hardiness is a big part of this. And you can, basically those folks are able to carry on their lives with fortitude, control, and commitment. And sometimes these come from seeking treatment afterwards. Now, in terms of childhood experiences, risk factors for developing PTSD after a trauma include living in poverty. As we've already mentioned when we discussed anxiety disorders, living in poverty is a very stressful situation, right? You sometimes don't even know if you're going to be able to eat that day. You might live in a neighborhood where there's a lot of crime, right? Or in very squalid conditions, whether you're in a rural or an urban setting. Also a history of psychological disorders in the family. So this could be genetic, but it could also be growing up with, let's say, a parent who has a psychological disorder, right, leads to sometimes a very chaotic upbringing and a lack of sense of safety. If you have been assaulted, abused, or experienced a catastrophe at an early age, so you've already sort of experienced a trauma, you're much more likely to develop PTSD after a trauma as an adult. And being younger than 10 years old when your parents separated or divorced. Now, side note about this, if the relationship is particularly contentious between the parents, it's actually really adaptive to get divorced. So the kids do better afterwards. Social support is one of the most important aspects for people with PTSD. This is really critical. So if you have weak social support, you don't have many friends or family members, you are much more likely to develop a stress disorder, either acute stress or PTSD. And we see this in particular in combat vets. And so again, some of that material they showed us is also about when they get back, and they talk about having a battle buddy even out, you know, once you're done with your military service, and checking on each other, things along those lines. And then feeling loved and cared for helps you to recover. And we see this in particular in sexual assault survivors. If they have friends, family members, a therapist, or the medical system that's really supportive, they do much, much better than folks who no one believes or who are rejected. The more severe the trauma and the more direct your exposure to it, so if it happens to you versus someone else, the greater the likelihood of developing acute stress or PTSD. Things that are especially risky include mutilation, severe injury, and witnessing the severe injury or death of others. In terms of explaining this from theoretical perspectives, learning theory, so a behavioral model, talks about the traumatic stressor getting associated with neutral stimuli in your life, right? So an example is some of my Iraq vets said the smell of sand, which I didn't even know until they told me that sand has a distinct smell, but the smell of sand would give them memories or flashbacks because they spent so much time around sand in Iraq. So they, like, if they go to the beach, which used to be a pleasant experience, this is now it's something that is linked to, it's a conditioned stimulus and linked to that traumatic stressor, which is that unconditioned stimulus. And they're both going to elicit that fear response, the memories, maybe even a flashback. Here is one of the few times, I will also hear this when we talk about somatoform disorders, that cognitive and psychodynamic theory basically say the same thing. So they argue that avoidance is a really important component of this, and the inability to integrate the event, so to process it, to, you know, give whatever understanding to it, to talk about it, to process your emotions related to it, those things are both highly linked to PTSD. So here's a good summary of those. Again, not something you have to memorize, but just a nice example of things put together. So I mentioned in passing that sexual assault survivors can experience physical as well as psychological issues. This is true for anyone who develops PTSD. People who are diagnosed with PTSD, we see them use the healthcare system more. So they're going to the doctor more often. They have more illnesses. We know that stress is related to our immune system. So if we're more stressed out, it's harder for our immune system to combat things. The most interesting study I've heard related to this is we had a grand rounds when I was in grad school, where they did a study that they consensually made little cuts in the mouth of med students and saw how long it took them to heal. And when they did that during midterms, it took, I believe, twice as long to heal as when they did it at a different part of the semester. Same exact place in the mouth, same exact everything, right? So stress is actually really linked to those things. Gastrointestinal problems can definitely be linked to stress. Cardiovascular health problems, heart attacks, things along those lines. Headaches, muscle pains, sleep problems. TMJ is a pain disorder in your jaw. And especially women who have been sexually assaulted, pelvic pain. They also experience senses of despair and hopelessness, loss of important beliefs. So if they are religious, they may sort of be like, why could God let this happen to me? Anger and aggressive behavior towards themselves or others. Self-blame, guilt, shame. This is going to put a strain on your relationships with others. They're going to isolate themselves socially, which is going to lead to less social support, right? Which is going to be problematic in their recovery. Identity issues, sort of who am I? Am I now just a victim? Who am I now that I'm not a soldier anymore? And then self-esteem issues, just not feeling good enough, things along those lines. All right, so how do we treat PTSD? We've actually developed a lot of methods that work pretty darn well now, which is great. With treatment, symptoms last an average of 3 years. I would say the majority of that is time prior to coming in. It takes a long time and a lot of courage for someone to come in because, again, they avoid thinking about this. When you go to therapy, you're going to have to talk about it. The clearest example I can give of this is I was in my late 20s when I was at the VA. And I had a guy come in who was just like 6 months younger than me. And his wife came with him just as social support. And so he was telling me like his Criterion A event was he was the first responder to a marketplace bombing. So you can imagine just the carnage, right? And he described it, and his wife turned to me and said, he's never told me any of this. One time when he was drunk and we were in the same house, he texted me about it. And that's the most I've gotten. It's really hard for people to talk about this stuff. So the thought of talking about it with a complete stranger can be extra difficult. So without treatment, it's even longer. And the treatment type will vary depending on the actual trauma you experienced, what's recommended. But in general, the goals of therapy will be to end the symptoms of that stress reaction, to gain perspective on the traumatic experience. So again, you're not going to like magically imbue it with meaning, right? But to help the person realize it wasn't their fault. And try to get them back to constructive living. All right, so cognitive behavioral treatments use what's called imaginal exposure. So with this, you're actually having the person either write out and read their story or just tell it out loud. And it's the same principle as what we talked about when we talked about systematic desensitization and snake phobia and flooding, right? But now you are, instead of, obviously it'd be unethical to like take a soldier and put them back in a combat situation, right, or to manufacture one for this. And obviously it would be completely unethical to like have someone assaulted again, right? But what you can do to sort of mimic that exposure is to have them tell their story, to sort of live it in their imagination. You also want to increase their positive coping skills and social support. And cognitive behavioral therapies are very highly effective, to the point that the VA, the year I was there, was starting to roll them out and essentially require them of anyone who's treating PTSD. There are also psychopharmacological things you can do. So giving them medications, SSRIs are the most common, but sometimes depending on their other disorders, their other comorbidities, they might be on sort of a cocktail of things to help them cope with their symptoms. So in terms of treatment for combat vets in particular, again, anti-anxiety and antidepressant medications may be really helpful. Behavioral exposure therapy. In particular, there's a type of therapy we'll talk about in a few slides called prolonged exposure therapy. And this is really good for if you have like one big traumatic event and you just have the person spend entire sessions telling their trauma over and over. And the goal of this is not to torture them, but to take away the power that that has over them when they try to ignore it, right? And let them face it and conquer it. You tend to use relaxation training with this as well. There's also a type here called eye movement desensitization and reprocessing, or EMDR. So this is where it's essentially exposure, like prolonged exposure, but while they're doing the flooding, you have them move their eyes in a very specific rhythm. Now EMDR has changed a little bit, so where there's like something you do with your hands with buttons. You know, I'm not actually that familiar with this, I'll be perfectly honest. There is research to back this up. It's unclear how necessary that EMDR component of it is, right? And how much of it works because you're doing the exposure, which we know works on its own. The article about this that always gives me pause is that they did this in blind people and it worked. So if there was something about like how you look while you're moving your eyes, it clearly, you know, it worked for them too. So again, that kind of suggests that that is the exposure component, unless it's something about literally moving the muscles of your eyes. I'm not sure. But if it works and people are more open to doing it, even if there is this sort of weird placebo component, whatever, okay, right? That's sort of my new philosophy, is like get people help and get them help with things that will work for them, right? Rather than wasting their time and their money. Insight therapy is about bringing out deep-seated feelings, trying to create acceptance and lessen the guilt. This can be used in family or group formats. Sometimes these are called RAP groups. At the VA, we called these process groups. For 2/3 of my time at the VA, I actually co-led a process group of women vets with PTSD. And they had a whole host of, you know, some were military sexual trauma survivors. One woman was a dental assistant, and she had to go through a whole bunch of bodies that had been burned and identify everyone by their dental records. I just can't, right? So those can be really powerful for them to get support from other folks. And actually, I think I'm doing okay time-wise, so I can take a quick pause and tell you my favorite clinical story ever, which came from that women's process group. So there was a woman whose dog had died the previous week, and she was obviously very sad about it. And so we were in group the following week, and that woman hadn't come for whatever reason. With these RAP groups or process groups, attendance isn't required every week, so you'll see people come and go. And I was leading the group on my own because my co-therapist was also the head of the PTSD unit, so she had something come up she had to do. And so it's like me and 20 women, and we're just trying to get through every woman. and help them, you know, give them space to talk that week. And so we get to the last woman and she said, okay, well, this week I just have a question. And I said, okay, that's good. You know, I'm thinking like, all right, we can get through this. And she said, what's that moving over there? And like, there's just this thing under a coat moving. And like, my irrational mind, because we were in the deep south, was like, it's a giant cockroach, but like, that would be implausible unless it was Gregor Samsa. And it turned out it was a baby goat. So one of the women actually lived in a rural area around Augusta. And she had brought a baby goat with her to group because her idea was she was gonna put it in the lap of the woman who had lost her dog and let her stroke it and snuggle it during group. And then that woman hadn't come, so she hadn't told us, hey, there's a goat over here. And the goat had, because it was a baby, had slept most of the time. So that's always like my very quintessential, like, I was in a place surrounded by rural places for internship, right, story. And we joked that like the VA needs to have a like no guns, no goats policy, but it was really adorable. And it had like a little like meh bleat and everybody ended up enjoying it. So yeah, that is the story about how someone bought a goat to the VA. All right, there's also something called psychological debriefing, which is essentially a form of crisis intervention that has victims of trauma talk about their trauma extensively within days of the critical incidents. They're talking about their feelings and their reactions. And there's 4 stages. So the first is normalizing responses. That's good, right? Other people feel this way. This is a normal thing you're experiencing. Encouraging expressions of anxiety, anger, and frustration, teaching them self-help skills, and then providing referrals to longer-term mental health care. What can happen is that relief workers themselves may become overwhelmed trying to do this, again, while they're in the midst of this crisis as well. And research on this type of intervention has actually called into question its effectiveness. Like, does it do anything to do it this quickly afterwards? And there's some research to suggest it might actually be harmful, that you actually need some time to process and be away from the situation before treatment can be effective. Now, in terms of sexual assault survivors, some of the similar things here, but the cognitive behaviorally based therapies are really the gold standard, but it can take on different forms here, and some would be more cognitive and some would be more behavioral. Stress inoculation training involves a lot of behavioral things, muscle relaxation, breathing control, modeling by the therapist, doing role plays for how you would address situations that come up because of your symptoms, put those in your lives, guided self-dialogues, like labeling your thoughts as irrational, substituting more adaptive self-verbalizations, and then what's called thought stopping, which is when you start to have negative thoughts, you just literally tell yourself, stop it. And this sounds bizarre, but thought stopping actually can work for some people. You can use exposure techniques, just like combat vets, where you would have the trauma scene relived in the imagination, out loud and in the present tense, and the detail included. And then cognitive processing therapy is a type of cognitive therapy that was actually created specifically for survivors of sexual assault or sexual abuse. So they do have people write down their story and then read it out loud. So I was actually doing cognitive processing therapy with my client I mentioned earlier. In fact, this is the type of therapy I did with every client I had on residency who had survived sexual assault or sexual abuse. And then you start to really dismantle fear structures and dismantle negative thoughts they have about themselves and the world around them. So ideas that it's my fault, things along those lines. Contradicting that self-blame. And EMDR can work here as well. So what are the components of cognitive processing therapy? There's 12 to 20 structured sessions, depending on the version you use. The VA version is 12 sessions. You first do a diagnostic assessment. And then you do psychoeducation about PTSD. So what are the symptoms? Why are you experiencing them? And also information processing theory. So this is an idea about how the cognitive symptoms of PTSD work. So like an analogy we would use is, you know, you're trying to avoid things that remind you of your trauma, but it's like you get a bill and you're like, I can't pay that now. So you just throw it in a drawer. And then like a month later, you open the drawer and you're like, oh, I never paid this, right? Like, even if you're trying to avoid the trauma, stuff can still come out and like catch you unawares with it, right? And we also talk about like schemas that we have. So we give analogies about like, you know, when kids are first learning about animals, everything with 4 legs is a dog, right? And then it gets more sophisticated, and that works in other parts of our lives too. And then there's cognitive therapy to address what they label as stuck points, but are really just those negative automatic thoughts that we've talked about. So their beliefs about themselves, each other, or other people rather, and the world. A lot of times these folks end up feeling like the world is just an unsafe place. So there are 5 main areas you focus on: safety, there should be a comma there, trust, power, self-esteem, and intimacy. As you can imagine, intimacy can be a really tough one for folks who their trauma has been sexual. And again, as I mentioned, you have them write their story twice and read it during session. Prolonged exposure, or PE, longer sessions, 10 to 15 sessions. And you again start with your diagnostic assessment. You do some education about PTSD and the same type of stuff we've talked about in class about learning theory. And then you have them do imaginal exposure. So for those 90-minute sessions, they are telling their trauma story over and over and over and over. And again, this is not to try to torture these folks. It is to take away the power that trauma story has over them, right? Facing it head on and realizing you can survive thinking about it. Eventually, you also work up to doing what are called in vivo exposure activities, where you have them, let's say, they've been avoiding Walmart because Walmart makes them think about marketplaces in Iraq. So you have them go to Walmart during the week, and you have, use your breathing techniques. And then the next session, how did that go? How did going to Walmart go? Hey, you made it 5 minutes. That's awesome, right? We'll work up to being there for a full shopping trip. All right, so now we're going to shift gears and talk just a little bit about personality and stress. So you've probably all heard of type A personality or type A behavior. This is also sometimes termed coronary prone behavior, named for the fact that these folks do have higher levels of heart-related conditions. These folks tend to be angry, hostile, cynical, driven, impatient, competitive, and ambitious. Everything must be just so, and we're going to do it this way because that's the way I said it. They talk with really pressured speech like this. And then type B, sometimes called cancer prone, doesn't really make any sense to me personally because cancer is not really like stress related per se, depending on the type. But these folks tend to be relaxed, less aggressive, less time concerned. So if we're talking stress, we think more about type A. So your odds of having a coronary event like a heart attack are doubled if you exhibit type A behavior. And they have 3 assumptions they make that really drive their day-to-day behavior. So self-worth is a function of achievement and recognition. So the only way they can like feel good about themselves as a person is like getting ahead and have others recognize them for that. No universal moral principle exists. So their thought is, I'm going to do anything I can to get ahead. Doesn't matter who I trample on. And then all important resources are limited or scarce. So life is a competition. And if I can't get this, someone else is going to get it. So I got to like fight my way out. So this is really similar to a disorder we'll talk about at the end of the semester called obsessive compulsive personality disorder. And this is also Freud's anal retentive personality. So if you remember, there's anal retentive and anal expulsive. Anal retentive is type A. It's being really uptight. It's wanting things a certain way, holding things in, right? Like a lot of Freud's ideas lend themselves to these type of strange analogies. So type A is like OCPD and also like Freud's anal personality. So what can we do for folks who have type A personalities? How do we help them to help both their physical and mental health, right? So this is sometimes called like developing a trusting heart. So we can help them revise their hostile beliefs, again, this competition sense, cultivate doubt and uncertainty, find ways to give and receive love, search for the beauty and joy in life, and consciously develop a healthy set of principles for living. Now, as you can imagine, it can be hard to get through to people with type A. Like, what talk about beauty and joy? Like, what are you talking about, right? But oftentimes you can kind of motivate them in different ways. These are treatments in general for stress that come out of what's a subfield of psychology called behavioral medicine. It's also sometimes called health psychology. So relaxation training, this can be helpful in treating both physical and mental conditions like anxiety or PTSD, but also things like high blood pressure. So this can be things like diaphragmatic breathing, progressive muscle relaxation, things that help you physically relax. Biofeedback is a really interesting thing. So it's basically relaxation training, but you're connected to some sort of output. So often it's something like an EEG or something that's taking your pulse or skin conductance, and you get continuous readings about involuntary bodily activities. And as you engage in these relaxation exercises, you actually see the change on the screen. So you immediately get feedback, which is really cool. Meditation is really popular in psychology now. There's actually, so in the cognitive behavioral family of therapies, they talk about the waves. The first wave is behavioral therapy. The second wave was cognitive therapy. And the third wave incorporates mindfulness and meditation. And so this is turning your concentration inward, achieving a slightly changed state of consciousness, temporarily ignoring all stressors. Again, shown to be very effective, can be super difficult for someone who's type A, for example, right? You want me to meditate? I can't just sit here, what a waste of time, right? But if you can get them motivated, it's very helpful. Hypnosis is another thing. This is again, an altered state of consciousness where you're more suggestible. So one of my grad school professors, Dr. Thomas Dowd, may he rest in peace, actually did cognitive hypnotherapy. And so he would put people into a hypnotic trance and use that to sort of lower their defenses related to things. So he did things like help people with chronic pain this way, and anxiety. And for whatever reason, I'm very hypnotizable. It's actually related to the big 5 personality trait of openness to experience. So I'm going with that. But so he often used me as a demo subject when he was talking about it to a class. And so I've had some cool experiences with that. And I remember every piece of it. You only don't remember if that's part of the hypnotic suggestion. Cognitive interventions can be just teaching new attitudes or responses to stress, right? Looking at stress in a different way, not blaming yourself, things along those lines. Insight therapy and support groups can be really helpful in realizing there are other people who experience the same thing you do. And then they also, again, can help reduce negative emotions, normalize things. And then combination approaches. You can combine, stuff on this slide with stuff on the previous slide. And that's especially helpful in changing type A personality patterns and reducing that risk of coronary heart disease in type A people. So I jetted through that faster than I usually do, but I skimmed some of the stats. Hang around for just 1 sec. I'm going to pull up the participants list because I'm guessing I missed some folks who joined late. So I just want to take attendance just because I want to make sure that basically I check up on people who are not here for several days in a row, and I want to make sure I don't need to check up on anybody. Alrighty. So I'll do my usual thing where I hang around for a minute if anybody has any questions. If not, I will see you for the exam at 9:30 on Thursday. Take care and happy studying.